All attendees are in listen-only mode.
Greetings. Thank you for joining us for today's webinar called Use of LSVT Loud and LSVT Big in Advanced Parkinson's Disease. My name is Laura Gousset, and I will be moderating today's session and presenting with my colleague, Dr. Cynthia Fox. Before we get started with today's session, we would like to acknowledge our funding support that has helped make LSVT Big and LSVT Loud possible in what they are today. So we are grateful to acknowledge support that we've had from the National Institutes of Health, the Michael J. Fox Foundation, the Parkinson's Alliance, and the Davis Phinney Foundation. So next, I'd like to go over the plan for the webinar so that you know what to expect. First, I'll cover some logistics and an introduction, and then I'm going to turn over the microphone to Dr. Cynthia Fox to cover a more extensive introduction on this topic, as well as to introduce the topic of LSVT Loud and Advanced Parkinson's Disease. I'll be coming back on after that to discuss LSVT Big and Advanced Parkinson's Disease, and at the time of our webinar today, we'll be able to go over any questions that you may have. So in terms of logistics, right now everyone in the audience is automatically muted so that there's no background noise from the various environments from which you might be joining us. But at the end of the webinar, there are a few ways that you can ask your questions. One is that you can type your question in the question box on your control panel. When I see that you have a question, I will read your question aloud to the group, and either myself or Dr. Fox will respond. The second way is that you can raise your hand. You might see a hand icon on your control panel. When you click on that, I'll be able to see that you've raised your hand. I'll unmute your microphone. I'll call out your first and last name to know that, so that you know that it's you being called on, and then you can ask your question out loud, and your computer will have to have some sort of a microphone capability in order for us to hear your question. The third way is that you can email us at any time at our email address info@lsvtglobal.com. We will be playing some videos during today's webinar. There aren't a lot of them, but please note that the ability to see and hear the videos will depend on your internet connection, as well as our internet connection as well. So it's possible that the videos might appear a little bit choppy, but we'll walk you through the content of the video. This webinar will be recorded so that if you have friends or others that you think might be interested in listening to this webinar, it will be available on our website in 1 to 2 weeks under the Patient Resources tab as an on-demand webinar. So now I'd like to give you a brief introduction of our presenters today. Dr. Cynthia Fox is one of our co-founders of LSVT Global and is the Vice President of Operations for LSVT Global. She is a world expert on speech treatment in Parkinson's disease with multiple publications. She has been part of the LSVT Loud and LSVT Big training and certification faculty for years, and has been involved in much of the research on LSVT Loud and LSVT Big. She's an expert on rehabilitation and neuroplasticity and the role of exercise in improvement of function consequence to neural injury and disease. I myself am a physical therapist. I've worked in a variety of practice settings, but I've focused most of my career on working with adults with neurological disorders. I've been an LSVT Big certified clinician since 2009 and have been an instructor for LSVT Big since 2011. I now serve as the Chief Clinical Officer of LSVT Big for LSVT Global. We would like to disclose to you that we have both financial and non-financial relationships with LSVT Global. We have a preference for LSVT Big and LSVT Loud as treatment techniques. Dr. Fox has ownership in LSVT Global, and both of us receive lecture honorarium and travel reimbursement. I myself am an employee of LSVT Global as well. The learning objectives are these. By the end of this webinar, we would like to give you a description of what advanced PD is and show you how we determine how the goals of LSVT Loud and LSVT Big may be a little bit different for those with advanced Parkinson's disease compared to those with early Parkinson's disease. And then we're going to list ways in which our treatment strategy can be really tailored to help meet the needs and the goals of people with advanced Parkinson's disease. So with that, I'm going to turn over the webinar for the next several slides to Dr. Cynthia Fox.
Thank you, Laura, for that introduction, and welcome everybody to the webinar today. We're delighted to have you with us. And what we're going to first do out of the gate is define what is considered advanced Parkinson's disease. And I actually saw that was a question that already came in from someone listening in the audience today. So it's important to define so you really understand what the sort of population that we're focusing with this particular webinar. Next slide. So if we look at the Hoehn and Yahr rating scale, and this is one rating scale used for people with Parkinson's disease, advanced stages are considered the later stages. And highlighted here in yellow are those advanced stages considered stage 4, stage 5. So stage 4 starts to have severe disability, but a person is still able to walk or stand unassisted. And stage 5, later stage, is wheelchair bound or bedridden unless unassisted. Next slide. Additional descriptions that sort of capture characteristics of advanced Parkinson's disease is the onset of motor complications, and this is despite aggressive pharmacological and behavioral management. And so oftentimes the motor complications that can occur in advanced Parkinson's disease are things such as wearing off symptoms and on-off fluctuations. So the medication may be working well, but then it wears off, and these can be dramatic shifts that occur and can occur quite quickly in some cases. Dyskinesias can be a motor complication, and these would be the increased types of uncontrolled movements that happen as a result of a long time, sometimes on levodopa type of therapy. Or a failure really to respond positively to medications any longer. Next slide. And so these type of motor and non-motor complications that we'll talk about in a moment really can dramatically impair quality of life. So it's very important from a medical team and rehabilitative team that we figure out how we can best control some of these challenges in advanced Parkinson's disease so that quality of life does not have to suffer. Next slide. So get a little more specific. What are some of the motor characteristics that happen in advanced PD? As I mentioned before, walking can become more difficult. Some individuals may actually become bedridden or choose to use a wheelchair or assistive devices. In many cases, patients are no longer able to live alone. And there can be a greatly increased risk for falling, which is not only disconcerting, it can lead to fractures such as hip fracture, wrist, arm fractures. But if you hit your head, it can also add a risk for a traumatic brain injury. And that's certainly, those are all things that are avoidable in many cases with rehabilitation. There may be an increased freezing episodes where, and this can happen, there may be certain triggers you have like doorways or changes of surfaces. There may be assistance needed for many of your activities of daily living, greater need for assistive devices and aids. And activities of daily living can be things like getting dressed in the morning, going to the bathroom, mealtime. And just increased severity of the common symptoms of bradykinesia, which is slower movement, hypokinesia, which is reduced amplitude, and rigidity. Next slide. Non-motor characteristics that may also happen in advanced Parkinson disease are things like dementia, psychosis and hallucinations, depression, anxiety, apathy, sleep disorders, autonomic dysfunction, and pain. And some of these can be managed medically with, and so if you're experiencing any of those, it's really important to let your care partner as well as your medical staff know. But as we talk about what we do in rehabilitation, and for this webinar, we're talking specifically about LSVT type rehabilitations, they may also help with things such as secondary pain and sometimes anxiety, apathy as well. Next slide. So in terms of speech and voice, we definitely see differential characteristics between individuals who have more advanced Parkinson's versus earlier. So in early Parkinson disease, the changes begin with a softer voice, monoloudness, monotone. There may be some hoarseness or breathy voice quality. And actually in some individuals, these are the first symptoms of Parkinson disease they notice. But people may perceive them not as somebody who has a speech disorder associated with Parkinson disease, but as perhaps bored or disinterested or apathetic. And so early speech intervention can help with that. Later, as the disease progresses, we get more involvement of the oral articulators. We may have more imprecise articulation. Sometimes vocal tremor can become a problem, and sometimes rate. Next slide. And so rate is really something I want to talk about in a bit more detail. And there can be a repetitive speech phenomenon that can be very specific to the dysarthria or speech problems in people with advanced Parkinson disease. And there's two different types of repetitive speech phenomenon. One is a more disfluent speech that's stuttering-like. These can be difficulties with initiation, repetition of syllables, inappropriate silences. And we've actually had patients report that perhaps they were actually had stuttering as a child, young adult. They've pretty much been able to manage it most of their adult life, but with the onset of Parkinson's, they've had more difficulty again in terms of controlling that disfluent speech. The other type of repetitive speech phenomenon is considered hyperfluent. Another term for that we use in the speech literature is palilalia. In this case, patients may have compulsive, effortless repetition of words and phrases against a background of increasing rate and loudness. And so this is not almost like festination and gait, where somebody perhaps gets going and can't stop. The speech in a pattern can have that happen as well. And later in this presentation, we'll listen to a video of a gentleman who really exhibits this hyperfluent or palilalia. The other thing we notice in terms of communication changes in individuals with advanced Parkinson's is they may need more time for processing and more time to prepare and respond. And sometimes it's educating communication partners that don't talk over somebody with Parkinson's, give them a little extra time so that they can initiate their response and or process the information you've shared with them. Next slide. So management of advanced Parkinson disease is not straightforward. It's complex. And this is just a flow chart of sort of the team of individuals and really a multidisciplinary team that can best manage all the symptoms, again with the goal of having improved and the best quality of life as possible. So that team is multidisciplinary. There may be non-invasive strategies, things such as pharmacological management, rehabilitation management, changing environmental strategies, but there can also be invasive strategies, which may be neurosurgical, so deep brain stimulation surgery. And those also work together in a multidisciplinary team of being paired with rehabilitation. And it's important to recognize there's no one script that's the same for all patients with advanced Parkinson disease. It's an individualized process to ensure best quality of life. Next slide. In terms of rehabilitation, as speech, physical, and occupational therapist, our goal for patients with advanced Parkinson's disease is really, first and foremost, as much as possible, to maintain or improve your physical capacity. And for speech, this is working directly to improve vocal loudness, vocal quality, pitch range, as well as speech intelligibility. In terms of movement, it's working to improve amplitude or bigness of movement, the qualities of movement, improving posture, as well as balance. And we know improving balance as well can be very important for preventing things such as falls. In terms of advanced Parkinson's disease as well, maintaining vital functions becomes more important. So we want to keep individuals safe with swallowing to avoid aspiration pneumonias, as well as moving safety, so we minimize the risk of falls, so we don't have those secondary consequences, as I mentioned, of a fracture or hitting your head. And the outcomes are really related to function, function, function. What is it individuals need to be able to communicate? What are the movements that are most important to enhance safety, as well as reduce caregiver burden? And we also recognize that sometimes we need to use strategies in addition to our sort of therapeutic intervention, and we may need family members, care partners to externally cue, and there may be augmentation, so the use of devices that will mention both related to speech as well as movement. Next slide. And so that multidisciplinary team, again, is key. You've got your medical team and your allied health team. And the focus of today will be on that allied health team, speech therapists who deliver our speech therapy, LSVT Loud, or physical or occupational therapists who deliver the treatment we'll talk about today, which is LSVT Big. Next slide. So now I'm going to delve into more specifically some considerations utilizing our speech treatment approach. And then I'll turn it back over to Laura, who will talk more specifically about considerations for our physical or occupational therapy. Next slide. So what we're going to look at now is just a videotape of a woman pre and post treatment. She was stage 4 Parkinson's disease, off her medication, and she had a lot of dyskinesias. Again, those are those increased movements secondary to medication. Actually, during the treatment session, she would often be quite dyskinetic, move to an almost frozen state, back to dyskinesia, and so presenting more of those challenges with advanced Parkinson's disease. And I'll just remind you, as Laura said, the video may be slightly lagged, but typically the audio should be quite good. So Laura, I'll let you start the video.
You first noticed something in your speech or your voice that you would associate with Parkinson's?
Well, at the time I was diagnosed, I had already had problems with my voice.
Mm-hmm. What kind of problems?
Getting hoarse mainly.
Mm-hmm. Okay, do this for me if you would. Take a deep breath and say ah for as long as you can. Would you say Parkinson's disease has caused you to talk less?
Yes, very definitely.
Why?
Because it's embarrassing and it's a strain to talk with people and make sure that they hear me. It's an effort.
Yeah. Do this for me if you would. Take a deep breath and say ah for as long as you can. Have you noticed changes in your speech or your voice following the therapy?
Definitely.
What have you noticed?
It's louder.
Good for you. Has anyone commented?
Yes.
Tell me about comments.
Well, several times answering the telephone, people say, Audrey, you haven't sounded like that in years.
No kidding.
And my older daughter said, boy, you must really be feeling good. You sound great.
Do you feel like you do more talking now since you've had speech therapy?
Yes, I can speak more comfortably.
Okay, so that's a nice example again of somebody, and even though the video was a little jumpy, she actually did have dyskinesias. And so those don't go away with treatment, but what does change is sort of the figure ground in terms of her communication. Her voice quality was not perfect after treatment, but it was better than where she started. And it's important to hear those things she said. She can speak more confidently, it's with less effort, and people notice that she sounds healthier, sounds happier. And she may have felt that way pre-treatment, but with the voice not being able to communicate that, she was perceived differently. So these are all important kinds of changes that can occur with behavioral speech treatment. So let's look at a snapshot of what a speech LSVT loud session looks like. On the left-hand side of the screen, we have our daily exercises. These are exercises that we do every day, and while they don't change, the performance of the patient changes, and we can make them more challenging. So one is those long ah that you heard Audrey do in the video, a minimum of 15 repetitions. Then we do high-low ahs, so ah, ah. Minimum of 15 repetitions each. That's helped to help improve intonation. And then we have each individual come up with a list of 10 phrases or sentences that you say every single day. It can be things like, where are my glasses? Or what's for dinner? And you practice those a minimum of 5 times a day so that when you go back home and say, where are my glasses? It's a reminder or hook or cue to think about the louder voice. Then with that loudness that we've scaled up in the first half of the session, we spend the second half of the session training that systematically into speech. And so across the 4 weeks, we gradually increase length of utterance from single words, short phrases, short sentences, maybe paragraph reading, conversational speech. And the materials we use are individualized to each patient, and it gets more complex. So week 1 may be reading words off the phrase. Week 4 is conversation. There's turn taking, a cognitive load, perhaps real-world environments. Finally, we assign daily homework all day 30 days of the month, as well as daily carryover exercises. Next slide. So for each of these exercises that I just briefly outlined, in advanced Parkinson's disease, sometimes we need to adapt them. We don't eliminate them. We keep all the exercises, but we can adapt them to the severity of the patient. Next slide. So for example, and this isn't an exhaustive list, but for the purpose of this webinar, to give you an idea of the types of things we may do. On those exercises of the ah, the long ah, the high ah, the low ah, as a speech clinician, we may need to spend more time shaping good voice quality. What that means is the voice may be more severely impaired when we start, so it takes more time and more attention to get good, healthy voice quality. In some cases, the duration of the ahs may be very short. It could be short as ah, ah. And so with that, we may do more repetitions. 15 is the minimum. In those cases, we may do 20, 25, 30, gradually building loudness and duration. We recognize individuals with advanced Parkinson's disease may need more time to rest between repetitions than our mid or earlier stage Parkinson's disease, and more extensive time for modeling and shaping and learning the target tasks. Next slide. In terms of those functional phrases, again, those were those 10 things that someone absolutely says every single day in daily life. In some cases, if there's some cognitive challenges, We may need input from family members to choose those phrases that are meaningful. However, I always give the caveat for family members, these should be phrases that your loved one actually says, not something that you as a family member want them to say. And that's very important because the goal of the functional phrases, again, is to build some automaticity. These are things the patient always says, and so we want to practice those in a loud voice. And similar to the previous exercise, we may need to do more repetitions. And I've actually had patients who are quite impaired, let's say stage 5, that my end target goal of treatment really was they could say 10, maybe 15 of these key functional phrases in the loud voice. And that was really our end goal of treatment. But in terms of impact on quality of life and functional communication, it had a powerful outcome for the patient and family members. Next slide. We also recognize sometimes in advanced Parkinson disease, reading, either because of visual impairment, cognitive focus, co-occurring language disorders, we may need to adjust the material. So if it's hard for a person to read, we can use repetition of words and phrases. If the patient can see but not read, we can use things like picture description. And so we can show a picture and we can go from name the picture, make a sentence about a picture, describe the picture in detail. Again, it's important for the speech language pathologist to allow sufficient time for slower cognitive processing and a response. Also, sometimes using the start of that helps rev up the system. So if the person is a little stuck, you can think of that as freezing in a sense in terms of language. We might go back and say, okay, do a nice ah. The patient goes, ah. All right, now with that voice, start saying these words or phrases. Next slide. And then calibration is what addresses barriers to generalization. So these are things like, it feels too funny to be this loud. How am I going to walk out the door and do it? And so even in advanced Parkinson disease, calibration is important, but it may be more challenging. Sometimes one of the tools we use, playing audio back, in advanced Parkinson disease, those changes of using loudness may not be as easily perceived. Kind of the benefit rewards of improved communication may be a little bit harder to establish, not always. But as a clinician and family member with our person with Parkinson disease, it's so critically important to find those emotionally salient or important opportunities when they use their loud voice and feel that positive reward of improved communication. And in the previous video, there was a nice example when the woman said, well, when I talked to my daughter on the phone, she said, wow, you must be feeling great. You sound so good. And those are the kinds of things we want to have happen. We may also need family members to help us complete our homework and carryover exercises. In individuals who may have some cognitive impairment, it's hard for them to remember to do those on their own. Next slide. And you can go straight to the next one there. So some additional considerations. In advanced Parkinson disease, the speech-language pathologist may not be enough. We might need support from family, from caregivers, from nursing staff to help with carryover. But we want to carefully train others on the most helpful way to cue patients so that it's helpful to our treatment goals and not hurtful. And so we don't want too much too soon. There's very simple, specific cues that we can teach family, and so that's a key part of the process. Also in therapy, as well as in communication at home, sometimes in our individuals who might have some more cognitive impairment, dementia, you can have islands of lucidity where the patient really is with you and you're like, wow, this is who I'm used to communicate. And we really like to capitalize upon those, both in terms of therapy, and it's a great time at home to capitalize upon those for communication, and recognize there's other times when our patients might not quite be present in the moment with us. And we've already talked about motor fluctuations, that we simply have to work through those on-off and those dyskinetic periods. Next slide. Some other simple strategies that we can use to adapt our environment is that we may need a treatment room separate from others and with as few distractions as possible, and particularly in early treatment sessions. So having other people around, other noises, things like that may be too distracting as we're beginning our treatments. We may want treatment without observers or other people in the room so that the speech language pathologist can focus specifically with the patient. Repetition, repetition, repetition. And one of the beauties of LSVT therapies is that the goal for the patient is quite simple. One thing to think about, loud or big. For the patient with advanced Parkinson disease, that can really be helpful to help them learn. In some cases, we also may need to treat beyond the 4 weeks, and there's nothing wrong with that in terms of having additional therapy. Next slide. We may, if possible, want to utilize some telehealth sessions. So it's very difficult for someone maybe with advanced Parkinson's to get into the clinic. This is what we call eLoud, and you can learn more about that in a separate webinar, and we have information on our website. And as speech language pathologists, family members, we need to acknowledge that sometimes patients fatigue. Validate that. I know this is difficult, but you're doing a great job. And again, give those longer rest periods. But advocate for our patients' speech and teach family and others around them strategies to wait for them. They have important things to say. And with simple cues of loudness, after practicing through repetition, giving them enough time, we can allow them to still have that important communication. Finally, we may need a bit more than just the cue of loud. And we always say, next slide. Do the behavioral treatments first. LSVT Loud is a great tool, but as I mentioned, you may need more treatment sessions. You may need more frequent and continuous follow-up. In some cases, you may need additional aids. Sometimes altered auditory feedback, something like the speakeasy, can be helpful. Augmentative communication devices may supplement. Oral communication may be limited to short phrases or sentences, for example, but an augmentative device can allow a person to express more complex communication. And finally, sometimes for palilalia, that hyperfluent speech I mentioned earlier, we may need pacing. And so we're going to look at a video now of a gentleman who had palilalia. And you'll see him in his pre-treatment interview, a short clip, and then in day 15 of therapy where he's using a pacing board.
So how do you say to my wife when I shy her off on the baby? And this is now left from something to follow me and go out to take my other ring. I got approached and the ship and I just wiped out. So I'm really so happy
Tell me a little bit about your experience here. This is session 15. We have one more session tomorrow.
Yes.
Tell me what you've learned from the therapy that you've done.
Someone have it down and talk slowly.
Uh-huh.
Use this board.
Okay. I want you to say that again using the board.
I learned to use this board to slow myself down.
Good. Okay. How about today, after you leave here?
Shopping.
Shopping. Tell me where you're going and what you're going to buy.
Food.
Give me a whole sentence without the board. I know it may not come out well, but it's for the camera.
Shopping.
Okay. Now with the board.
We are going food shopping.
Okay, Laura, that's good on the video. So just a few words on that. Obviously, the use of pacing really helped improve his speech intelligibility. He needed both, but loud alone wasn't enough. And so these are additional strategies that your speech pathologist might be able to use to maximize communication. With that, I'm going to turn it over to Laura now, who's going to talk about some considerations for LSVT Big in advanced PD.
Muted. Unmuted.
Thank you, Cynthia, for that really interesting presentation. Many of the statements that Cynthia gave about LSVT loud are really applicable to LSVT big as well, because you have to think of Parkinson's as one disease, and the LSVT big and LSVT loud protocols are essentially the same but applied to different parts of the motor system. So LSVT loud applied to the speech motor system, and LSVT big applied to what we call the limb motor system. So I want to give you a snapshot of what LSVT big looks like, and then we'll delve into looking at adaptations and considerations for treating people with advanced Parkinson's disease. So in the LSVT loud session, you saw that the participants do a loud ah as in addition to their highs and lows and functional phrases. In LSVT big, we do something called maximal daily exercises that you see on the left side of the screen. And these exercises really train our patients how to move more normally, how to move bigger like they did before they had Parkinson's disease. So we work in movements in sitting and in standing typically that move in all planes, forward, backwards, sideways, rotational movements, because we know that in function you need to move in all directions for different functional activities that you participate in every day. On the right side of the screen, you see functional component tasks, and instead of picking out key phrases, our patients choose brief, simple motoric activities that they participate in every day. Some examples included below are sitting to standing, maybe reaching for a cup or a drink, or even something simple as pulling up the covers in bed. So these aren't complex movements, but we practice them very repetitively. Under that, you see hierarchy tasks, and in speech, they work on building the complexity and endurance of using the voice for functional communication. In LSVT big, we work on building the functional use, complexity, endurance of a more complex motor activity that has multiple steps to it, like the ability to get out of bed to use the commode chair at night, or maybe transferring from the wheelchair to a different surface more independently, more safely, with less assistance, or getting in and out of the car. So these tasks are really customized to the specific needs and goals and wishes of each patient. And then lastly, we always work on big walking in every session. If the patient is able to take even a couple of steps, we still consider that walking. So in some patients, that might be walking with a rollator or a walker or a cane or no device. And so we really try to adapt even big walking to that patient. Something that's not included on here is the carryover assignments, and Cynthia mentioned that for LSVT loud, and that is also part of the LSVT big protocol. So every day at the end of our session, we assign the patient a new way of using and trying out their bigger movements functionally in whatever they had planned to do for that day. And that really helps the patient to carry over and generalize use of bigger movements to all aspects of everyday life. So here you can see a snapshot of two of our maximal daily exercises, and typically these are the only two that are done from a seated position, and these exercises are unique because we work on sustaining a certain posture. You can see she's sitting up in really nice big posture, and in the side-to-side exercise you can see she's got that nice big stretch of her leg, and she's got nice big posture and a big arm movement. And we really practice holding those positions because we know functionally It's very useful and valuable to be able to hold your posture when you're sitting, maybe at the edge of the bed getting dressed, or using the bathroom, or even sitting and eating a meal. There's also multi-directional repetitive movements in the standard protocol. These are done in standing, and they work on stepping different directions with big arm movements, forward, sideways, and backwards. And then lastly, we have 2 repetitive rocking movements where it's a rocking movement either forward and backward or side to side with coordinated arm movements. So just looking at these pictures, even though they're not dynamic videos, you can tell that they might be challenging movements and even positions to get into in someone with more advanced Parkinson's disease, or someone who's simply older and has more comorbidities such as arthritis, joint limitations, and pain and such. And so that really helps us to bridge into this topic of how do we adapt the LSVT big protocol for someone that has some of these complexities that we see every day. So there are many reasons for adaptations. One of them is to reduce fear of falling. And fear of falling is interesting because even people that don't fall can have fear of falling related to lack of self-efficacy, anxiety. There's visual perceptual changes that can occur with Parkinson's. Certainly changes in balance occur in the moderate to later stages of the disease. Increased problems with freezing of gait. All of those things contribute to a fear of falling, and so certainly if we're doing exercises, we want our patients to be confident so that they will feel comfortable practicing not only in the safety of the therapy environment where the therapists are guarding them and helping them, but also at home, because the great expectation is that for optimal improvement, our patients are required and really need to practice these things every day on their own. So we want them to be successful so they feel like they can do them at home in a safe manner. And this really positively reinforces this idea that yes, I can move bigger and it's okay, and it feels good to move bigger, and I know how I can do it in my home environment. It really supports motor learning in the presence of cognitive and non-motor complications. And so sometimes we have to simplify these very complex movements because really cognitively, at least initially, it's challenging in some patients to even coordinate upper and lower extremity movements successfully while keeping the amplitude maximal. Sometimes a patient is able to do a nice big rocking or stepping movement, but then when we add in the complexity of the arm movements, everything gets small again. We recognize also that in advanced Parkinson's disease, there's more likely to be comorbidities, and part of this is just because of the age group that is usually seen with Parkinson's disease tends to be older to middle age. And as we all know, with aging, our joints start to wear out. We start to have problems with musculoskeletal dysfunction, sometimes increased problems with blood pressure, things like this. And so as therapists and healthcare professionals, we really need to think critically about how to adapt movements and therapy and exercise so that it's safe for each and every person, regardless of what comorbidities they might have on top of Parkinson's disease. And lastly, Cynthia mentioned there are dyskinesias and motor fluctuations on and off times that can occur with Parkinson's, and as therapists, we want to make sure that even if a person has severe dyskinesias, we are creating an environment and a setup so that they can perform their exercises and therapy in a safe manner, whether or not their dyskinesias are present, or maybe they're in a wearing off time and need to learn how to move during those times of days as well. So here are some treatment strategies that we typically employ if there are physical concerns like balance concerns or orthopedic concerns. If a person still is standing but is somewhat unstable, and typically these are patients that need to use a walker or a cane, we simply give them more support, either on with one arm or with both arms. If a patient is unable to stand altogether, we can adapt the exercises to a sitting position or a supine position. And some of this is just temporary in the first week or two of treatment until the patient's movements and balance improves, and then we can progress them to a standing position more safely. For the therapist providing the treatment, with people with advanced Parkinson's disease, often it requires more intensive and frequent physical shaping of movements to make sure that the movements are good quality, and more modeling of movements. And that really is a term just saying we show our patients how to move in a way that is the way that we want them to move. During those sustained exercises, we might need to reduce the hold time because it might be, difficult to sustain a big arm movement with big posture for 10 seconds. But if we can start at 2 or 3 seconds and build up from there, it's valuable for the patient. The same thing goes for repetitions. We don't cut out any of the exercises, but we do sometimes decrease the repetitions so that really the focus can be on good quality big movements. And I often tell my patients I'd rather have 2 or 3 really big, good quality movements rather than 10 that are small and not of good quality. So I'm going to give you a few video examples of different ways that we can adapt exercises and some of the rationale. So in this first scenario, this gentleman that I'm working with here, we are pretending, actually, he was a nice gentleman and he does have Parkinson's, but was kind enough to shoot some videos for us. And the first one, you're going to see a little stool there. A lot of times when our patients first come in, they have back pain or severe stiffness in their back and can't reach all the way to the floor during the movement, so we can put a little stool there. And in the second scenario that you'll see is a real common scenario where a patient comes in and has maybe an old rotator cuff injury or an old shoulder repair and doesn't have full range of motion on one side. So here's a little snippet of that.
Okay. And hold big.
2, 3,
4, 5, 6, 7, 8, 9, 10. Okay? Out big, down, up, good. And hold that there.
2, 3, 4, 5, 6,
7, 8, 9, 10. Good.
So we might be saying the word big, but really what we mean is big as each patient can be in a safe manner. If a person has a bad joint, we're never going to make them move so big that it's going to be damaging or painful to that joint. Here is an example of an exercise adapted in standing for safety. This is an example of what we might do if a patient needed a lot of support, maybe someone that couldn't stand without holding onto something at all.
When you break the step and reach to the side exercise down into components, it's similar as step and reach forward. What you want to do, Bob, is hang on with both hands for good balance and take your big step to the side, out, and then back in. Go ahead, now you do it. Out and in. Good. One more. Out and in. And try the other leg. Good. One more. Good. Now for the arm component of that one, I want to make sure that your feet are about shoulder width apart for good balance. Does that feel pretty good? Mm-hmm. Use your big posture, and we're going to do that big arm movement and look out to the side. Why don't you look to the left when you do it? Big arms, and then a big finish. Good. One more. Big arms, and then a big finish. Good. Now let's do it to the right.
Okay, the next video example is of a woman that really wasn't able to stand safely at all, and so we were able to adapt her exercises to a sitting position. And I'll just show you a quick example of that. Go for it.
Forward. Good. Bigger arms. Bigger, more deliberate. Good. Go for it. Atta girl. Bigger arms. That's it. Big feet, big arms.
Okay, so it just gives you a little example of what we do as therapists is really critically think about each patient and decide what our patients need for each exercise. So all the 7 maximal daily exercises are the same, but they're not the same in the way that we deliver them to each patient. So part of the treatment protocol is called functional component tasks, and I briefly mentioned those when I showed you the snapshot slide, but we choose 5 movements that are meaningful to the patient, and we practice those repetitively, so at least 5 times or more for each of those every day. And here's some examples that might be pertinent to someone with more advanced Parkinson's disease. Could be something as simple as being able to uncover oneself in bed or turn over in bed. I know that can be very frustrating to feel stuck in bed. Or maybe it's to be able to lift one's legs in and out of the car independently without their spouse or caregiver helping them. We also work on these hierarchy tasks, and normally they're a very complex task with a certain length to them. But for someone with more advanced Parkinson's disease that moves slower and processes slower, it might need to be a shorter hierarchy task. So instead of a task of the patient completing, total body dressing up, the shirt, pants, shoes, socks, everything, we might simplify it and say, you know what, your hierarchy is going to be getting on a shirt because that was the most challenging and the most important thing for the patient to be able to learn how to do more independently and efficiently. It's important for us as therapists to allow sufficient time for slower cognitive processing and response, and our patients typically need more cues throughout that long task to think big and to keep it big, as well as increase cueing at home as well. For big walking, I think one of the most important things is to make it salient to the individual's own walking scenarios, especially if the patient is provided with therapy in a different setting, like an outpatient hospital setting where there's wide open hallways and smooth surfaces and no obstacles. It's very, very different than an individual walking in their own home where they have to maneuver around furniture and obstacles and changing surfaces and going through multiple doorways. And so for our patients that have advanced Parkinson's disease, often it's very valuable to provide treatment in home, and if that's not possible, to as much as possible simulate those situations. For patients that have problems with freezing of gait, we incorporate treatment strategies to help patients learn how to conquer those. We definitely include big walking with assistive devices as needed, so focusing on big steps, big posture. And just like with a hierarchy practice, oftentimes our patients with more advanced PD need more verbal cueing to help them sustain their big movements for a longer duration when they're walking. Just like with LSVT loud, calibration can be more challenging, but it remains just as important with people with advanced Parkinson's disease. And the same thing with LSVT loud. When we play back videos, they might not easily perceive how their movement is slower or smaller than someone that has earlier Parkinson's disease. And thus, it's difficult sometimes for the patient to really understand the benefits and the rewards of improved movement, especially initially. Usually those come in the later weeks of treatment. So it's really important for us as therapists, for those of you that are listening that may be therapists, to find those emotionally salient opportunities so our patients feel the reward of improvement in movement and function, because that really helps to motivate people to keep up with therapy and with exercise after therapy. So just like with LSVT loud as well, our treatment may need to be provided in somewhere with less distractions, without observers, and the real key is practice, practice, practice. So our patients not only need to practice intensively when they're with us, but they need to practice intensively at home and after discharge as well. And this really takes a team. It's important to very early on establish who will be your coach and help you and support you and hold you accountable and help you with your daily exercises long term. So we feel that everyone deserves a chance. We don't discount successful treatment options because the disease is advanced. It's very old school thinking, and we know now that even with advanced Parkinson's disease, through intensive rehabilitation, people with advanced PD can have amazing outcomes, and functional communication and movement of any time can dramatically improve quality of life, even if some supplementation of other therapy or increased assistance from caregivers is needed. So in summary, we want you to know that LSVT loud and LSVT big are applicable to all stages of Parkinson's disease and can be customized to each patient's needs and treatment settings. And these protocols increase independence, speed, quality, and safety with communication, mobility, and ADLs. Our goal is to restore function, improve function, and maintain function for all of our patients. Advanced Parkinson's disease does carry unique challenges that require creative solutions and increased caregiver involvement, but those solutions are there and hope is there for our patients as well. For further information, if you are interested in receiving treatment and you haven't yet, you can go to our website, and there's the first tab is called Find a Clinician. You can find an LSVT loud or LSVT big clinician in your area. Please join us for more webinars in the future. We have upcoming webinars that are available live, like you're listening to today perhaps, or recorded, so available on demand. Those are found under the Patient Resources tab on our website. Those are really for anyone with Parkinson's disease, healthcare providers that are not LSVT big certified or loud certified, or maybe even physicians or caregivers or family members of those with Parkinson's disease. So they're free, and we really hope that you enjoy our webinars. If you have any questions, you can always ask the expert by emailing info@lsvtglobal.com. If you're interested in receiving LSVT loud and LSVT big, or perhaps you have in the past, we'd encourage you to consider getting the Homework Helper DVD, because they're very useful in supporting your home practice and keeping you motivated long term. Cynthia may have mentioned the LSVT Loud Companion, and there is a patient edition that can be used at home. It's a software program to support your practice of LSVT Loud in the home setting or through telehealth. So please email us if you'd like more information on the LSVT Companion. Next year, we are going to be launching Loud for Life and Big for Life. We're very excited to announce that. They're going to be group maintenance classes for people that have gone through LSVT Loud and LSVT Big. So please stay tuned, and we'll make a big announcement. If you're a therapist watching us today, please note that we have two research grants for treatment research. We've just announced our LSVT Loud, or I should say our speech therapy grant for speech therapy students. And in the spring, we'll be offering grants for PT and OT students as well. So email us if you want more information on that. So with that, we are right at 5 o'clock, but Cynthia and I are happy to stay on and answer a few questions if you have any questions. If you think of any questions after the fact, once again, email us at info@lsvtglobal.com. So I'm just going to see the questions we have here tonight. Okay, Cynthia, I'm going to give the first question to you, if you don't mind. And the question is drooling improved with voice therapy?
That's a great question, and the answer is sometimes yes and sometimes no. And so what we really see is that some drooling, if it's mild, may be the result of pooling of saliva, in some cases due to lack of awareness. So through the motor exercises, and there's a lot of swallow that happens in LSVT lab, drinks of water, more movement of the oral cavity, people do swallow more and they feel like they have better control of their saliva. In other cases, that may not be true. They may actually need additional either behavioral interventions that address the swallow, and in some cases, patients actually do have some Botox that are in the salivary glands that can help control really excessive saliva, which then may manifest in drooling. So it'll be a piece of differential diagnosis of the nature of the drooling, and certainly you can try the behavioral therapy. Patients may decide, yep, I feel like it's managed well enough, and if not, may seek additional options.
Thank you, Cynthia. I'll take the next couple of questions here. One is, has anyone considered incorporating Feldenkrais? And that's an interesting question. We certainly get lots of questions often about combining the LSVT approaches with other types of treatment. And one of the great things that we're very happy about is that there is a lot of great literature and research coming out on different treatment options for people with Parkinson's. At this time, we haven't done any research on combining it with other types of treatment approaches, and therefore we can't make that type of recommendations. However, LSVT big and LSVT loud are well supported in the literature and could be considered as one type of treatment option for people with Parkinson's disease. The next question is this. Sometimes when I'm training big walking, patients have difficulty incorporating arm swing and they begin to look awkward and robotic. Is it better to have them work on big stepping first and arm swing separately, or keep practicing it together? So Christina, you sound like you're probably a therapist. And what we have found in LSVT big traditionally is that if we just keep it simple and keep the cue on big and focus on modeling of that big movement and shaping the patient's movement through our modeling, generally over time that big walking starts to look less awkward, less robotic. Initially, certainly it often does, but it's a signal to me as a therapist that the patient just needs continued modeling and shaping on my part. And if you're not an LSVT big certified clinician, I would suggest that you consider training, because that'll give you some more information on treatment and application of big walking as well. Okay, one of the questions is a copy of this PowerPoint available? And yes, I'm so glad that you asked that. After today's webinar, probably tomorrow, we'll be sending everyone a handout of this presentation today so that you can have that for your reference. If you are a listener listening to this as a recorded version, please email us and we can supply you with the handout for this webinar. And I believe the last question today is someone that is a question that I should probably answer as well, Cynthia. I have a patient whose dyskinesia is so bad that sometimes I worry he's going to fall out of his chair. Are there any big tactics that he could use to help control these movements? He has difficulty completing his daily exercises due to the dyskinesia. So yes, I have also had some patients that have had such severe dyskinesia that they nearly fall out of their chair as well. And so I think you need to think about this from two angles. One angle is from the medical management side of this patient's medication, probably his carbidopa, levodopa. It's worth a conversation with the physician to see, if the physician agrees that this patient is optimally managed. Sometimes there's other treatments that the patient ultimately needs, like DBS, and so there's a good team approach. Secondly, it's good to understand when in the medication cycle these dyskinesias are occurring. For some patients, it happens at peak dose, but I've also had patients that have dyskinesias when they're wearing off, and so at least initially during the first couple of weeks of treatment, it's ideal to schedule your treatment time when they're less likely or least likely to experience dyskinesias, and that might be in their medication wearing off time, for example. Over time, what I found through my experience is that although the patient still does have dyskinesias, their core balance and core control is better, so that even though they're experiencing dyskinesias, they never bring them to that point where that they would fall off the chair or fall in standing. They're able to stand with a wider base, they're able to sit with a wider base, they're able to sit in bigger posture, and this just gives them overall more stability when they're moving, whether it be in sitting or in standing. So with that, I believe that we answered all of our questions today. One second, I think there is someone that has raised their hand, and that is Doug Joch. And Doug, I'm going to unmute your microphone, and please ask your question out loud. And you might need to unmute your own microphone, Doug. You'll see a green microphone on the top of your control panel. It looks like you are self-muted. Okay. I'm not seeing anything happening, Doug. I'm sorry. If you are still there, please email us your question at info@lsvtglobal.com, and we'd be happy to answer your question after the webinar today. So with that, I want to thank you for joining us today and taking time out of your schedule to listen to this webinar. We hope it was valuable information to you. If you have any suggestions on topics that you'd like to see in the future, we're always happy to receive those. So please email us. And thank you again. We hope that you all have a good day.
Thank you. Bye-bye.